Right, we're talking about the Biomechanics, the Langer Biomechanics Summer School that's coming up in June. And you're going to give us a presentation about the effects of our interventions. So do you think this is something that a lot of practitioners are a little bit unaware of?
Yeah, I mean, I think the big issue really is we don't have a lot to guide us. And what most of us have done over the years is to really think about, we gauge whether or not we're successful because someone feels less pain. We've got so little information in the literature that actually allows us to have a kind of good assessment structure. You know, if you're trying to teach people, how do I assess someone? There are methods that we can use, but there's no clear pathway that's got a good evidence base. So that then takes us on when we then intervene. We don't have a good way of knowing whether or not our interventions are making things better, other than whether someone feels less pain or not. What I've observed over the years is because we've been fortunate enough to be able to use things like in-shoe pressure analysis and more recently 3D gait analysis, we can actually objectively see what we're doing to the foot when we change either footwear, give people certain tasks to do, or put insoles orthoses in the shoes. And what I've learned is that actually it can be difficult to predict, and sometimes the information is quite surprising.
Right, so that would be very interesting to hear more about that, especially in light of the fact that a lot of the evidence and a lot of the papers do actually contradict each other. Now, one of the topics we're going to have in the great debate, we're going to talk about plantar heel pain. Now, everybody sort of says plantar fasciitis is the most common thing we cause. Do you think that condition is overdiagnosed?
Well, it depends what you mean by overdiagnosis. I mean, the most common problem we see is plantar heel pain. But for me, it's a bit of a bugbear, I have to be honest, because although we term it plantar fasciitis, or if you want to be more precise, plantar fasciosis, actually it's a whole range of conditions. And for a number of years now, for our resistant cases, we've been using MRI scan. And we see a whole range of pathologies, and that ranges from just simple thickening of the fascia with it can be with intrasubstance edema. We can see partial or full thickness tears. We can see fat pad edema. We can see intrinsic muscle edema, and importantly, bone edema, which can either be of a spur of the plantar calcaneus, or in fact a whole chunk of the calcaneus. So we're dealing with, excuse me, frog in the throat without the beer. What we're actually dealing with is a whole range of pathologies that all contribute to plantar heel pain. So subsequently, when we look at the studies that deal with plantar fasciitis, actually in a lot of these studies, they don't know what they're treating. It's fine to use ultrasound, which is a great clinical tool, but all ultrasound really does is tell you whether or not you've got a thickened fascia and if you've got an unusual pathology.
Right, excellent. And obviously it'll be interesting to see what the other speakers have to say about that as well. So I'm sure that'll be a good talk. So finally, can you give us a quick biomechanics tip for those out there listening?
A quick biomechanics tip. Actually, I'm going to err slightly away from biomechanics to say I think biomechanics is a fundamental part of our process. But there's a saying that says if all you have in your hand is a hammer, then the whole world looks like a nail. So if all you have in your armoury is to be able to treat someone with biomechanical principles, and you don't think of the pathology and the other treatment options, then you're not doing your patient a good service. I think people need to consider that the biomechanics approach we take, accepting all the limitations that we have because of a lack of evidence, is part of our management process. And if you're not getting the response that you desire for the patient, either refer them on for more in-depth analysis, whether or not that's into a gait lab or whatever, or move them on to the next step of the either investigation or management pathway, whether that be injection, shockwave, or even surgery.
Excellent. So really, let's not be precious and keep patients to ourselves when they could be referred on.
Yeah, it's interesting, because I often with patients, I will say, I will give them the whole gambit of treatment, which will end in surgery, even though I want to start them with maybe orthoses. Because if the orthoses don't work, they don't then think they failed.
No, that's excellent. Thank you very much, Trevor.